Yeah. I'm audible? Sarita?
Yes, madam. Yes, madam. You are audible, ma'am.
Yeah. My screen is visible?
Yes, madam.
Let's start again.
Yes, madam.
Yeah. As I told you earlier, the topic allotted for me today is Sanniruddha Guda. We'll also be talking about anal stricture and imperforated anus. And one more condition, that is Pada Vikriti, where we'll be talking about clubfoot or talipus equinovarus and valgus. My slides are visible, Sarita?
Yes, madam. Yes, madam.
Yeah.
Slides are visible, ma'am.
Yeah.
Yes, ma'am.
Yes. Yeah. Sanniruddha Guda or anal stricture. The reference of which it is available in Sushruta Samhita and in Ashtanga Sangraha under the concept of Shudra Roga. It is mentioned under Shudra Roga. There are many Shudra Rogas mentioned. Among that, one is Sanniruddha Guda. The shloka of which goes like this: वेगसन्धारणाद् वायुः विहितो बुधमाश्रितः निरुन्नति महास्रोतः सूक्ष्मद्वारा मार्गस्य सौक्ष्म्यात् कृच्छ्रेण पुरीशं तस्य गच्छति सन्निरुद्धगुदं व्याधिमेनं विद्यात् सुदुस्तरम्. And the shloka from Ashtanga is like this: Anukarotihi bahya antamargasya ततः शकृत कृच्छ्रेण निगच्छति व्याधिश्च रुद्धगुदो मतः. That is because of we'll talk about the topic. First we'll talk about the nidana, then the samprapti, then lakshana, sadhya sadhyas and chikitsa of the disease. First coming to the nidana aspect, vega sandharanat vayuhu, that is because of Vega Sandharana. Which Vega Sandharana is Mala and Mutra Vega Dharana. What happens is there will be Niru Vihito Vayu Budamashitaha. That is the Vayu situated in the Buddha gets vitiated. This causes Nirunnati Mahasrotaha Sukshma Dwaraha Karoti. That is, it narrows the Buddha Pradesha and causes avarodha of the Mahasrotas. Okay. And because of this narrowing, there will be Krichrena Malagachati. There is difficulty in the defecation. And the last part of the shloka, he tells about how is it, he talks about the sadhya sadhyata, where he tells that vyadi menaha sudustaraha, that is, it is a kashta sadhya vyadi. And in the shloka mentioned by Ashtangakara, he tells anukaroti bahya antamargasyaha. There will be narrowing of bahya and anta gudamarga, and Shakrat Krichrena Nigashtati. There will be difficulty in the passage of stools. Such a disease is called as Ruddha Guda. So it may be asked as Sanniruddha Guda or Ruddha Guda. Both are same terms. Next, we'll talk about the treatment. The treatment, he tells that I'm audible. I believe I'm audible. Yeah. Sannirudha Guda Gude Yojam Niruddha Prakasha Kriyaha. That is, Niruddha Prakasha is one more Vyadhi which is mentioned in Kshudra Roga, where they tell that Sanniruddha Guda should be treated in a similar form like that of Niruddha Prakasha. Same explanation we get even in Ashtanga Sangraha and even in Ashtanga Hridaya. Okay. According to Sushruta Samhita, he tells that in Sanniruddha Guda and in Niruddha Prakasha both, dilatation of the narrow Sankuchita Guda Marga should be dilated using a yantra called Ubhayamuki Nadi Yantra, that which is made up of Loha. Ubhayamuki Nadi Yantra means that the yantra should be opened both the sides. Okay, and before dilatation, he tells that it should be dipped in Ghrita priorly to the dilatation. Then he tells uh, the same procedure of dilatation should be done every third day by increasing the size of the Nadi Yantra. Okay, this is for a better dilatation. He tells that every third day the size of the Nadi Yantra should be increased and it should be used for dilatation. Right. Next, after dilatation, he tells Parisheka should be done. What is Parisheka? Parisheka is a type of Sweda, and he tells the yoga for Parisheka as Chakrataila. Vasa and Majja or Vatanashaka Dravyayukta Chakrataila should be used for Parisheka. We get a commentary of what is Chakrataila from Dalhana, where he tells that Sadhyo Piditaudruta Taila, that is Taila which is freshly extracted from the chakra, that should be processed with the Vasa, Majja or some Vatanashaka Dravya, and that should be used for Parisheka. And in the last part, we get explanation regarding what Patya should be followed, where he tells that Snigdha Annapana should be given. This is the reference we get regarding Sanniruddha Guda. Next topic is anal stricture. Before speaking about anal stricture, I would like to tell few conditions where you can find difficulty in defecation, and among that we will be talking anal stricture and imperforate anus in detail. We can find difficulty in defecation in children in case of anal stricture, in case of intestinal obstruction, less seen in children, and diverticulum, if there is congenital megacolon, which is also called as Hirschsprung's disease, or if there is any functional obstruction, or if there is imperforate anus, and if there is any worm infection, in all such conditions you can see difficulty in defecation. So, the first topic here, we'll be talking about anal stricture. We'll start with the definition of the topic. Anal stricture is nothing but the narrowing of the end of the anal canal that takes stool outside the body. There will be narrowing. The cause may be different. There will be narrowing of the end of the anal canal which helps to take the stool outside the body. This has one more term is anal stenosis. Anal stricture and anal stenosis are both the paryaya padas. Okay. Next, what are the causes? The causes goes like this. If there is any congenital anorectal malformation, or if there is any rectal trauma or any infection in the rectum, if there is any intestinal malabsorption or any surgeries of the anal canal is performed, this acts as the cause for anal stricture. Here, the first cause, congenital anorectal malformation. Congenital anorectal malformation, one such congenital anorectal malformation is imperforate anus, which we will be talking about detailedly today. Next, how is this anal stricture classified? We can find two types of classification of anal stricture. Um, one first classification is based on the severity, and the second type of classification is based on which level, at which level we find the anal stricture. The first classification based on the severity is mild, moderate, and severe. In mild type of anal stricture, what happens is, here anal canal can be digitally examined with lubrication, digital lubrication. Okay, and in a moderate type of anal stricture, anal canal cannot be examined, or it can be examined with the difficulty, with the lubrication. And in severe anal stricture, what happens is, it is not possible to examine the anal canal digitally. Normally, this examination is not done in children. Digital anal examination is not done in children since it is a little painful procedure. The second type of anal stenosis is low, middle, and high type of anal stenosis. This classification is done based on at which level anal stenosis is present. A low level, here the stenosis will be present below the dentate line, and the middle anal stenosis will be present distal to the dentate line, and high anal stenosis will be present above the dentate line. Just I would like to mention what is dentate line here, because you would have studied it in anatomy, but still, dentate line is a line which divides the anal canal into upper 2/3 and lower 1/3. So based on at which place the stricture is present, it is classified into low, middle, and high anal stricture. Next, how would the patient come to you? Okay. What are the complaints the patient will come with when he or she is suffering from anal stricture? There may be constipation, there will be painful defecation, and sometimes you can see rectal bleeding also. Okay, these are the three main signs and symptoms with which the patient comes to the doctor. How can you examine? Normally, and the diagnosis is done by visual examination of the anal canal or the perianal skin. Normally, in kids, we don't go for digital examination until it is very much necessary. Okay. Next, the treatment. Here, the treatment is of two types. One is conservative treatment, and the second one is operative treatment. Most of the times, if the child just complains of constipation and painful defecation with the mild anal stricture, we can go for conservative treatment, where you can give some stool softeners and some fiber-rich diet or some fiber supplements. In a severe anal stricture, it may need dilatation, which is an operative procedure, or an anoplasty. I think this completes anal stricture. Next, we will be talking about imperforate anus or anal atresia. Imperforate anus or anal atresia, it is a congenital malformation. The treatment here is most of the times only surgical. Okay. Definition. The definition of imperforate anus goes like this. It refers to a spectrum of anorectal abnormalities ranging from membranous separation to complete absence of the anus. It includes agenesis, atresia of the rectum, and anus. That is, here there may be just a membranous separation, or there may be complete absence of the anus, based on the severity of the imperforate anus. Next is, what is the incidence? 1 in 5,000 live births, the child suffers from imperforate anus or anal atresia. Male child gets affected more compared to the female child. Classification. How is this imperforate anus classified? It is mainly of three types: high type, intermediate type, and low type. In the high type, intermediate type, or low type, this classification is also based on the level of imperforate anus, or basically where imperforate anus is present, at which level. Based on that, this classification is Based on the anal canal level, this classification is done. Before going into detail about the uh, classification and its explanation, I would like to talk about what is cloaca. For cloaca, it is a common passageway for feces, urine, and reproduction. Okay, at one point of development of human embryo, it will be a common passageway, and this is called as cloaca. It is the far end structure of the hindgut. It is the far end structure of the hindgut, which in later developmental stages, it gets divided into the rectum, the bladder, and genitalia in the human. Sometimes it does not get developed properly, causing one of the congenital errors, that is imperforate anus. Next, we'll be talking about what is a high type of imperforate anus. In the presentation will be different in a male child and in a female child. I have shown the slides how it would appear, right? High type of imperforate anus. Here there will be no anal opening present, and the rectum ends above the muscles of the bottom of the pelvis or hip bone. Here the child may be having fistula. Okay, here in the high type there is no anal opening at all, and the rectum ends above the muscles of the pelvis. Rectum ends above the muscles of the pelvis, and there is fistula most of the times. Okay, intermediate type. Here the end of the rectum and anal canal extends through the muscles of the bottom of the pelvis. It is still more lower. It extends still a little lower, little into a lower position, where the end of the rectum and the anal canal extends through the muscles of the bottom of the pelvis. Here also the child may have fistula. There may be fistula here. Next coming to the last type, that is the low type of imperforate anus. Here the rectum ends below the muscles of the bottom of the pelvis. Here an anal opening will be present but in an abnormal position, or sometimes it is just covered by a membrane. Two things may happen, or else there may be presence of anal opening but it will be in an abnormal position, or sometimes it is covered with a membrane. These are the three types of imperforate anus. Next, the signs and symptoms. There will be no anal opening when you physically examine the child after birth. There will be no anal opening, or sometimes you can see a misplaced anal opening. That is, anal opening will be there, but it will be in an abnormal position. Or anal opening may be very near to the vaginal opening in a female child. And one more thing what you can see is there will normally meconium should be passed within 24 hours after birth. Here the child will not pass the meconium within 24 to 48 hours of birth. And what happens is, because of the presence of the fistula, stools is passed through the vagina in a female child, or it may be passed through the urethra in a male child. And there may be abdominal distension or blotting of abdomen. How most of the times, how can we do the diagnosis of this imperforate anus? Diagnosis is made at birth only. Most of the times, diagnosis is made at time of birth. When you check the anal opening during the newborn physical examination, as dealt in earlier classes, immediately after birth, when you go for a neonatal examination, physical examination of the newborn, then you can find this abnormality. And very rarely this is diagnosed antenatally. Antenatally, if this imperforate anus is associated with some other congenital anomalies, it can get diagnosed. And in anomaly scan, sometimes with the assistance of MRI, if you have a doubt and you take the assistance of MRI, then you can diagnose it by 24th or 25th week. But chances of antenatal diagnosis is very less, most of the times missed. Okay, next, coming to the treatment. The treatment depends on what type of imperforate anus the child is suffering from. First, we'll go talk about the treatment of low type of imperforate anus. In In the low type, normally what they do is the membrane can be opened by the surgery. If there is an anal opening present, which is covered by a membrane, the first thing what they do is that membrane is opened surgically, and since there is a little anal stricture, anal opening is narrow, they may go for repeated dilatation of that opening. If the in low type, what happens is the anal canal is sometimes in an abnormal position. In such condition, surgical reconstruction of the anal canal is done. In high and intermediate type of anal stricture, single surgery will not be sufficient for its treatment. Over a time period, 2 to 3 times the surgeries should be performed so that the child gets a normal anal canal. First thing, what in high type, it is corrected with the surgeries over a period of time. Okay. First, what they do is a temporary colostomy is done, where rerouting of the bowel outside the abdominal wall is done using a colostomy bag, so that the baby can pass the stools into the colostomy bag. Okay. This is the treatment in high type. After rerouting the bubble into the colostomy bag, when the child attains 3 to 9 months of age, seeing the general condition of the child, second surgery is done. Okay, for the surgical reconstruction of the anal canal opening is performed. The surgical reconstruction is done. Uh, and at the same time, at the age of 3 to 9 months, when the anal canal reconstruction is done, at the same time, if there is any fistula present, that should be closed. 6 to 8 weeks later to this surgery, what they do is the colostomy bag is removed and the colostomy is reconnected. This is the treatment which is performed. This is the treatment which is performed in the case of high type and intermediate type of anal stricture. Most of the times, we have to also go through what is the outcome of this treatment. Patient, even after surgery, may come to you with certain complaints. Okay, now more in low type of imperforate anus, the outcome of the treatment is most of the times very good, and chances of any complaints are less. Okay, child with imperforate anus sometimes may be constipated even after surgical repair. As I spoke to you in anal stricture, any surgery performed at anal region may cause anal stricture. This may be also one cause which causes anal stricture, leading to constipation. The second common complaint post-surgically seen is stool incontinence, which is a very troublesome complication the patient suffers from. Child as well as the parents, it is a very troublesome complication. Child with the low type, or if in case the child is suffering from a stool incontinence, the child who was suffering from low type of imperforate anus would gain the bowel control earlier, but the child who had suffered from intermediate or high type of imperforate anus, what happens is they may take a long time to gain the bowel control. It may take like when the child up to the school age, or even sometimes the child may reach the adolescent when it attains the bowel control. This is one thing we have to take care of, or even the parents will be very much concerned about this complaint. Okay. I think I've spoke about imperforate anus. Next topic allotted today is Pada Vikriti, which is also termed as club foot. Okay. We will start the topic with the definition of club foot. This is also one more inborn error in the children, okay, or a congenital deformity in children. The definition is, it is a condition in which one or both the feet are in abnormal position at birth. The condition is also known as talipus equinovarus. That is, it is a condition where when the child takes birth itself, the feet of the child is in abnormal position. The incidence. It is a common birth deformity. It is seen in 1 1 in 1,000 live births. 1 in 1,000 live births, the child suffers from club foot. 50% of the times it is bilateral in nature. 50% of the times this is bilateral, and sometimes only one foot is affected. And here also it is more seen in males than compared to the female child. The ratio being 2:1. What are the causes of club foot? The causes of club foot till date is not known, so it is termed as idiopathic. But certain observations are done. Most of the times there is a positive family history, and abnormal position or restricted movements in the uterus may also cause club foot, or arrested or anomalous development of the uterus. Development in the uterus is also said to be a cause of club foot, but the exact cause of club foot is not known. Next, coming to the types. There are, even though, as I told you earlier, common one is Talipus, equinovarus, and valgus, but there are many types of club foot. And it is termed based on the positioning of the foot. The types are like this: Talipus varus, Talipus valgus, Talipus equinus, Talipus equinovarus, Talipus equinovalgus, Talipus calcaneus, Talipus calcaneovarus, and Talipus calcaneovalgus. We will talk about each in detail. Okay. What is talipus varus? Talipus varus is a congenital deformity of the foot in which the foot is rotated outwards so that the walking is done on the outer side of the sole. Here the child walks, when the child walks, the outer side of the sole touches the ground. Okay, outer side of the whole outer side of the sole touches the ground in case of talipus varus. In talipus valgus, it is a congenital deformity in which the foot, here the child, so that the walking rotated inwards. Here the foot is rotated inwards. So when the child walks with the inner part of the sole. The child walks with the inner side of the sole touching to the ground. Third type is talipus equinus. This is also a congenital deformity of the foot in which the sole is permanently flexed so that the child walks only using the toes without touching the heel to the ground. Here what happens is that it is a congenital deformity. What happens here is the child walks only using the toes where the heel of the child does not touch the ground. Okay. And talipus equinovarus. Talipus equinovarus it is a combination of talipus equinus and talipus varus. That is, it is a congenital deformity of the foot in which both we can see both equinus and talipus varus, so that the child walks on its toes with the outer side of the toes touching the ground. Talipus equinovalgus. This is also a deformity where there is a combination of talipus valgus and equinovalgus. That is equinus. That is, here only toes of the child touches the ground with the inner part of the toes touching the ground. Heel does not touch the ground. Next is talipus calcaneus. What is talipus calcaneus? It is a deformity due to weakness or absence of the calf muscles in which the axis of the calcaneus becomes vertically oriented. That basically the heels of the child is touching the ground here. Okay. Next is talipus calcaneovarus. This is a congenital deformity in which there is a combination of talipus calcaneus and varus. That is outward bending with the talipus calcaneus condition. Here, what happens is the marked dorsiflexion, inverted and adducted foot is seen. Next is talipus calcaneovalgus. This is a congenital deformity with a combination of talipus calcaneus and valgus. Valgus means here there will be dorsiflexion, everted and abducted foot. This is a slide showing different types of club foot based on the positioning of the foot. If you go through the definitions, seeing these diagrams, you will understand it better. How is the diagnosis done? How can you diagnose a club foot? Most of the times, club foot is diagnosed antenatally. It is possible to diagnose club foot antenatally with the help of ultrasound scanning. Most of the times, within 13th to not 13th, I mean by 25th week of pregnancy, in ultrasound scanning, it can be diagnosed. And after birth, it can be detected by the physical examination of the baby by seeing the shape and the position of the foot. By seeing the shape and the position of the foot, it can be diagnosed. And the X-ray help us to see the level of bony deformity, or the X-ray helps us to see how much the bone is deformed. These are the diagnostic procedures used in case of club foot. Here, next we come to the treatment. Mainly, treatment is conservative and surgical. Here, conservative treatment is mainly, the aim of conservative treatment is to correct the deformity. Deformity can be corrected by using a cast or a splint. When we come to the cast, two types of cast application is commonly used. One is Ponseti method and other one is the French method. What happens is, in Ponseti method, the doctor moves the baby's foot into a correct position, and it is placed and a cast is applied to hold the baby's foot in that position. And this repositioning is done every week and cast is applied. Such process should be continued for months together till the child's foot comes to a normal position. This is called as Ponseti method, where, I repeat again, where the doctor corrects the position of the child's baby's foot and a cast is applied to maintain that position. It is maintained for a week, and again after a week, once again repositioning is done, again a cast is applied, and this is repeated for months till the child attains the normal positioning of the foot. This is called as Ponseti method. The second method used is the French method. Here there is a little difference. In Ponseti method, they manipulation, correction or of the foot is done every week. Here, what they do in French method is daily manipulation of the infant's foot is done, and they also stimulate the muscles which act on the foot of the baby, and to maintain the corrected foot, what they do is immobilization of that foot is done using a non-elastic adhesive strapping. Non-elastic adhesive strapping is used to maintain the correction. This correction is done every day in case of French method. Both the Ponseti and French method are proven to be effective, but it takes a long time period. After this, you can also use a splint called as Dennis Brown splint. Next, after this correction, the next thing what the doctor has to see is whether the correction is maintained. Maintenance of the correction until normal muscle balance is developed. See, once it is corrected to some extent, next the child is advised to wear a club foot shoes. Okay, so that the child can attain a normal muscle balance to walk properly, and follow-up has to be done to see whether there is any reoccurrence. And surgical correction, if there is any tightening of the ligament, or if you need any lengthening of the tendon, for relaxing the tightened ligament and to lengthen the tendon, you have sometimes we have to go for a surgical correction. I think this ends club 4. Anyone have any doubts? You can ask. Thank you.
Thank you, madam, for nice presentation and detailed presentation. Now the topic is open for discussion. If anybody have any doubts.
I was audible throughout the session, Sarita?
Yes, madam. Yes, madam.
Yeah.
Clear it is. Madam, with Ayurveda in Pada Vikriti, can we do anything?
Yeah, see, we can go with the Abhyanga, Padabhyanga and all, just to soften the muscles, and it may help the positioning of the muscles after the removal of the cast. Basically, application of the cast is very important to bring the foot back to its normal position. Bringing back the foot to normal position only with Abhyanga will not be possible, but after bringing it to the normal position, to maintain that position, to strengthen the muscles of the foot, yes, our treatments like Abhyanga, Shashtika Shali Sveda and all will be helpful.
Yes, ma'am. Which oil would you suggest, ma'am?
For
Oil for Abhyanga and all, ma'am.
see, any Vatanashaka Taila, because here we can find structural deformity also. So I feel any Vatanashaka Taila along with the Sveda followed, if it is Shashtika Shalipita Sveda, I feel it is better. That can be advised periodically, like with 14 days of course once, again repetition after a month or something. That will help in the softening of the muscles and maintaining the corrected posture of the foot. Any Vatanashaka Taila will.
One more question is there, ma'am.
Yeah.
Imperforated ANS Ayurveda correlation.
I couldn't hear you, Sarita.
Imperforated anus Ayurvedic correlation, ma'am.
Imperforated, see, that's what I told. Sanniruddha Buddha is one thing which is explained in Ayurveda, where in the shloka they have explained only narrowing of the anal canal. Our see exactly we don't find any correlation for imperforate anus. Just seeing the clinical feature, difficulty in passage of stools or no passage of stools. Based on that, we can just correlate it with Sanniruddha Buddha. As such, there is no exactly like imperforate anus. There is no references.
Okay, ma'am. Any question from the participant side? Other participants?
Yeah, I forgot telling. This question will be most of the times not asked as a long question, 5 marks or 3 mark question. It would come for 5 marks or a 3 mark question. It is not asked as a long essay type of question.
Any more questions from the participants? I think no questions, ma'am. No further questions. Thank you so much, ma'am, for a nice presentation. Even though the presentation is short, but it was very sweet presentation. And I hope it will useful definitely for the UG students. They can understand the topic and definitely, even though it is asked for a short question, but it is definitely useful to them and in the practical oriented and in the practice also in future also it is very much useful for the Vikritis. Clinically they can diagnose it. Okay, ma'am. Shall we end, ma'am?
Yeah, ma'am. Sure, sure. Thank
Yes,
you.
ma'am. Thank you so much, ma'am.
Thank you,
Once
Sarita.
again.
I also thank Sarita for giving me this opportunity. Thank you, Sarita.
No, ma'am, it's my it's my thing, ma'am. I should thank you, ma'am. You are readily agreed to share your knowledge with us and students, ma'am. Thank you so much, ma'am. Thank you, ma'am. Okay, everyone. I wind up the session. Thank you. Thank you, one and all.